Holt, who's our editor of the Southern Medical Journal, to change their talks, and they've graciously done that. And if you notice too, the footprint of Southern Medical, a lot of the Ebola crisis is going on in our footprint. Texas, Atlanta, even NIH is up in Dr. Goodman's territory up in the DC area. So it's all right fresh on our minds. Let's see, Dr. Bibbins has agreed also to be available in between in the hospitality area for questions and answers, and she also did a very nice clinical documentation presentation for us previously in September, and that's what she was supposed to do tonight, and she's agreed to answer questions. If you have those, you can direct them to her in between. So, without further ado, the first speaker is Dr. Betty Bibbins. She's President and Chief Medical Officer of DocuComp and founder and Dean of the Faculty of DocuComp LLC. They're the first nationally recognized program that provides clinical documentation, specialist education, and certification for hospital clinical staff and their support personnel. She's recognized for her dynamic leadership, team building, and public speaking skills. As part of my office staff attended her previous presentation, they speak very highly of her. We appreciate again her willingness to reformat her lecture tonight on Ebola and other biohazardous contaminations, and we hope we don't have to face those. Now I'll turn the platform over to Dr. Bibbins.
Thank you very much. Okay. Hello, everybody. I'm Betty Bibbins, and we're going to talk about, are you prepared in your practice for possibility of transmissible, infective, or biohazardous patient exposure? And keeping in mind, yes, we're going to be talking about Ebola, but we also have to keep in mind that Ebola is a viral disease, and this is coming on the toes of our flu season. And so one of the main things we are really encouraging everyone is to get flu shots. We're going to have to be able to differentiate many ways of what's going on, but a lot of what we're talking about today can be used generally in infectious disease control within our offices when we have infected patients being like in waiting rooms or throughout our practices with non-infected patients. What do we do? How do we triage? What do we do to determine the severity of illness? And to a point, what do we document? There are some areas we'll be hitting across the board that we need to be aware of in general throughout the practice of medicine, and especially with Ebola, because we never know when someone is just going to walk in our door with a communicable disease that needs to be seen immediately, and we need to take extra steps for this patient to protect our staff as well as our patients. Okay? So we'll start with the big one, screening for Ebola. Okay? It's a two-step process. First are the signs and symptoms of Ebola viral disease, which are the signs and symptoms, majority of them, of a viral infection, such as, now keep in mind, I will put a caveat at the beginning of this. Like at the beginning, this is updated October 28, 2014. Something in this presentation probably has already changed since I did this yesterday morning, all right? And I don't know what the status is in Maine of the lawsuit, okay, with Hickox. And so that some may be changed by the time we leave this meeting. There may be guidelines, new guidelines for us. So this is, again, as of October 28, 2014, this was just put on the CDC.gov website, that any of this information we have, you can get it even more up to date there. Okay, fever of, as of before, 38.6 degrees Celsius or 101.5 degrees Fahrenheit, which has been modified to 38 degrees Celsius or 100.4 degrees Fahrenheit. So anywhere in that range, elevated temp. It could be objective or subjective, and we'll get to that in parts of it, that a patient can have subjective, I have a fever, with other symptoms such as severe headache, this is above and beyond a headache, muscle pain, vomiting, diarrhea, viral, abdominal pain, and we have unexplained hemorrhage, but it can start out in early phases as unexplained bruising that can progress to unexplained hemorrhage in more advanced cases. And patient having traveled to West Africa in areas of Guinea, Liberia, Nigeria, Senegal, Sierra Leone, or other countries that may be evolving as we stand here now, where EVD transmission has been reported by the World Health Organization, where they've been there in at least the past 21 days, keeping in mind that Ebola can express itself anywhere from 2 to 21 days, with the average being 8 to 10 days from exposure. So this information is what's important when we gather data. When basically the patient comes in with the signs and symptoms, usually in early phases of a viral infection in the flu season. How do we differentiate? Have you done any travel? Now, where you put this in your practice is where you determine your comfort level is. Do you do it at time of appointment, at time of screening? Do you take walk-in patients? Okay? Some patients may find that they feel more comfortable coming to a physician's office than going to an emergency department. They may not have the money for an ED visit, but they can afford an office visit. So we don't know where the next patient is going to walk in. And if it's our door, are we ready for it? Okay? Okay, again, if both criteria are met, patients should be moved to a private room, which in the office, usually you don't have to worry about that. This is also for inpatient with his own bathroom. And this is kind of iffy. They definitely have changed the personal protective equipment for inpatient to full equivalent to biohazardous gear. Full face shield, cover of hair, no exposed area on the body whatsoever, nothing on the neck. Okay, a full respirator for instead of a mask, and complete non-permeable over clothing, along with pants and booties that come up at least mid-arm, and something that we can keep in mind, double gloving instead of just single gloves. So that's something that can be done in the office. We may not have the full protective gear that would be used inpatient. Again, inpatient, the patients are usually already definitively diagnosed or strongly, significantly symptomatic of having Ebola or a severe communicable disease. But in your office, it is still questionable, various risk factors that we'll go over in a little while. Okay? So what we need to do, okay, as of now, full personal protective equipment, or at minimum, contact and droplet protection, okay? Precautions throughout the office. And one of the things we also have to keep in mind is we need to have a reason. We need to have a method in our office for our staff to query patients and to get them out of the waiting room, either into an office or back to their personal car to go where they need to go. Health department, emergency department, local facility, or where, if there's significant reason to feel that this patient needs to be biocontained, okay? And they have something communicable. So we need to have some process in place in your office that if a patient with the symptoms comes in and the history, whichever way, we will talk about a couple of ways to do it, that you can capture that information, then how do you get that information to who needs to know it, other than the front desk or check-in, sign-in, or triage area? Does it go to your office manager? Does it go directly to the physician? Okay, who else is notified? Health department, transport, EMS transport, the emergency department, if it is significant, okay? So we need to start getting precautions and protocols in place. But this not only needs to be for Ebola, but anything significant, any disease that is transmissible. Keeping in mind flu season, you can have one person come in and infect your entire waiting room, and we don't know how severe the flu may get or may not. Keeping in mind, tens of thousands of our patients die each year from influenza, and this will be a greater, significant impact on our office practices. Okay, screening criteria available. Okay, put the screening criteria up. Do you make sure that the staff in your triage area or at your main sign-in desk are aware of the signs and symptoms? It's up to you. Do you have your staff to query them in the open? Do they wait until the patient moves back? Do you do it on the phone? Someone calls, you ask specifically about travel. Have you traveled out of the country lately? That can be, it doesn't have to be, have you been to West Africa? Okay? It can be, have you traveled out of the country? If so, where? That starts at a non-threatening question where the patient may automatically want to say no just to get in the door. We don't need to stigmatize it ourselves. We need to keep ourselves open so that our patients will be open to us, so that we can communicate and provide the best care for them, whether it is in our office practice or whether we direct them to take their personal vehicles directly somewhere else, or someone who's already been with them to take them somewhere else, and then prepare the facility we're transferring them to or sending them to be prepared to be there for them. There has to be communications, written communications as well as telephone direct communication, human being to human being. Okay? So we have the posted listings of criteria throughout the office. Some may even have them, again, non-threatening. If you travel outside of the country, please come up to the desk immediately upon entry. Okay? Or you can have your person ask them immediately when they sign in, why are you here to see the doctor? We usually already know that one way or another, about travel, or fill out the forms. Okay? And for phone screening, consider doing an algorithm in your office. If the patient says yes, then you do this. If the patient says no, you do that. And whatever level of comfort that you have, who is the next step after the patient signs in, is either sign in or triaged in to your office? Who is then the core person, central person in your office who needs to determine where the information goes? Is it your office manager? Again, is it the physician? This is something you need to start thinking about if anyone with any major problem walks in. What is your protocol? This is where we have compliance. We need to have policies and procedures. It could be for Ebola specifically or for any type of quarantinable, communicable disease. We'll go from there. Hey, screening, again, criteria be available. And one of the most important things that they're finding out when they compare facilities that had staff become exposed and develop Ebola from a patient who had it versus those facilities that did not have staff develop Ebola, is that their staff personnel were trained specifically in the personal protective equipment use and the appropriate use of personal protective equipment. You don't walk in a room with the personal or PPE and then walk out of the room into the hallway where everyone is. Okay? You have to have an area or at least leave everything as you come out the door to that room. You need to stay in the room. Okay? Conduct spot checks. Educate and then spot check to make sure that your staff are doing what needs to be done. Everybody gets busy. But so we need to make sure that not just now, where are we going to have trouble, potentially. It's when down the road, when all the Ebola may have calmed down, they're still saying people with Ebola exposure are still leaving the countries. Yes, they're screening them for their temperatures as they leave, but that doesn't mean they're not going to get a temperature 4 hours later. Okay? 1 day later, 8 days later, 20 days later. Okay? So people with exposure to Ebola are still getting out of the countries and maybe, like I said, getting symptomatic the next day or time after they're being screened. So we need to be aware that our staff need to keep this up to date even 1, 2, 3, 6 months, a year from now, when the scare is over, but the threat is still there until we get it controlled. Okay? Identify your patients. Early recognition is the #1 thing. They have done research and identified that the greatest survival rate is when, if a patient has Ebola, if they get treatment begun before 4 days of symptoms. Okay? This may change as information changes, but right now, the greatest survival rates are for 4 days or less of any symptoms. So, they have different categories that this is just hot off the press, so we have it here, we'll go over it. Instead of low, moderate, and high categories, they have one is no identifiable risk. Again, we're just getting the new information on it every day, and the knowledge and that we know about this disease is growing every day as we study it more. This is no identifiable risk includes contact with an asymptomatic person who had contact with a person with Ebola. So that's a second generation, second degree exposure, all right? Contact with a person with Ebola before the person developed symptoms, having more than 21 days previously been exposed in a country with widespread Ebola, but they are asymptomatic. Having been in a country without widespread Ebola transmission and not having any other exposure as defined. That is a beautiful way that a governmental organization says no exposure identifiable. All right? They haven't been to a country with Ebola, and they haven't had contact that anyone knows of with someone with Ebola. And so this is what we call no identifiable risk. Okay? The next level of severity of illness is the low but not zero identifiable risk. And that includes having been in a country with widespread Ebola virus transmission within the past 21 days, having brief direct contact, such as shaking hands with someone while not wearing personal protective equipment, with a person with Ebola who was in the early stages of the disease, brief proximity, such as being in the same room for a brief period of time in a patient with Ebola while the person was symptomatic, and in countries without widespread Ebola transmission, direct contact with others using appropriate PPE with persons with Ebola while the person was symptomatic. And if they're asymptomatic, then they are placed on various forms of controlled movement monitoring. We'll go over that in a second, even more so. So those two there, then we get to some risk. And this category is in someone who's been in countries with widespread Ebola virus transmission, direct contact using appropriate PPE in a patient with symptomatic Ebola, close contact in households of healthcare facilities or community settings with a person with Ebola while the person was symptomatic. Keep in mind, Thomas Eric Duncan, all of the family members that lived with him while he was symptomatic and then stayed in the contaminated apartment for a number of days after he was hospitalized, not a single one of them developed Ebola. And they were in close proximity with him for approximately 2.5, 3 weeks while he was asymptomatic and then symptomatic also. And then you have 2 nurses, one who had been in approved PPE at that time for her whole time, Amber, contact with Mr. Duncan, and then the other where there was 1 day to 36 hours of minimal protective equipment being utilized, and then complete protective equipment. So we're still trying to figure out, to a degree, transmission, or is it mutating? That's a big question there. In a different environment, different hosts, is it mutatable? Yes. Is it mutating? They'll have to see. There are a number of strains of it. It's not just one. There are multiple ones. Okay? And so then we have, well, if a patient is symptomatic with some risk, that is when we start putting the patient, implement rapid initiation and isolation of the patient. Until the test is positive, it's all hypothetical and theoretical, but you still protect the public. So until the patient is diagnosed positively with Ebola, that is why we're using the various degrees of quarantine and isolation, and now we're calling it active and direct monitoring, and we'll go over that in a little while, okay? And then we have patients who have high risk for the Ebola. And this is percutaneous exposure or mucous membrane exposure, either like a needle stick or droplets or coughing, that type of thing. Exposures to body or body fluids of a person with diagnosed Ebola and symptomatic. Exposure to the blood or body fluids, including but not limited to saliva, feces, sweat, urine, vomit, and semen of person with symptomatic Ebola. Processing of blood or body fluids, okay, lab personnel. Do we get a urine as soon as a person hits our offices? Okay, double gloving, protective equipment, personal protective equipment as best as possible in our office practices. This is good for all times. Okay, processing of blood or body fluids in appropriate PPE, direct contact with the deceased without appropriate PPE in a country with widespread Ebola, as well as having lived in an immediate household and provided direct contact to a person with Ebola and symptomatic. Okay, so these are the types of categories that we have, that basically varying degrees of exposure for the first degree, second degree, whether the patient is symptomatic or asymptomatic, and that would determine where they go. But on the whole, they don't go in a hospital unless there's signs and symptoms warranted, whether they have Ebola or not. Okay? Identifying a patient, this is what we have said, basically 21 days, they've traveled in the country, they have the signs and symptoms that we are saying, that we've mentioned above, the signs or symptoms of a viral infection, and come from an area, biggest component, either exposure to a patient with Ebola or come from an area, have traveled from an area recently from a patient from a country that has Ebola there. Maintain awareness of infection control. We need to distribute, have education, have a 30-minute meeting with your staff to get everyone up to date and on the same page regarding things such as hygiene, hand washing. That may seem like, oh, well, we do the alcohol-based foam. Yeah, but there are times that that's not appropriate. There are times that it is. Okay? And so if there are body fluids or any other liquids that there's direct contact with the hands, you don't just use alcohol foam. We wash hands. Good old soap and water is the first line, if we have contact with it, with or without gloves. And then if there is no direct contact per se with bodily fluids that are known, then the alcohol-based foams will be fine. Maintain awareness of any communicable diseases that come through your office, Ebola being the main one now. Review and update your policies and procedures, and basically for patients with Ebola, for triaging them, as well as if you feel that the patient needs to be isolated, if they do come to your office and they're highly symptomatic, and you can't just send them out. You have to take care of them until support comes to transport them. Then you have to be ready. Do you have your staff knowing how to clean equipment using bleach and water, 10 to 1 or 1 to 10 dilution, or antiseptics? that are viral sprays and solutions that are used hospital grade for viruses that have envelopes and non-envelope viruses. And this is where you read in little flyers that come with the sprays and the disinfectants. Okay, this is what you need to be aware of. Make sure you're not using something thinking, hey, this is good enough, when it isn't. Make sure you have appropriate quality. It's worth it, with the thoughts of if someone walks in and your staff is exposed to it and you don't have appropriate disinfection for any type of disease process, infectious disease. This is where we need to take care of that now before we need it. Ordering it tomorrow won't help today. Okay? Okay, education and training, healthcare personnel receive job-specific. Lab people know what they need to do in the lab. Office personnel, nurses, medical assistants know what their jobs are. Triage, screening personnel know what their jobs are when it comes to anyone walking in with a significant possible communicable disease, Ebola being one of them. But others, if a patient just comes in with severe diarrhea, do they have Clostridium difficile? Okay? These types of things we need to know now and make sure our staff knows now and not after the fact. Okay? This includes employed physicians from outside agencies, independent contractors that work with you, volunteers that work with you. Sometimes they fall between the cracks. And the strength of our chain is as weak as its weakest link. And if we do all the training of our office staff on isolation and on hygiene and on respiratory etiquette and hand washing etiquette, we don't teach our volunteers or our students that rotate through the office that come through, or any independent contractors we use for filling empty slots when someone's sick or out of the office. We need to make sure everyone gets the training. Okay? General education, that's the same thing. Update list of diseases that are reportable. This is where your office manager would be the most helpful. Okay? And facility and demonstrate compliance with mandatory reporting requirements. Do you know what the mandatory reporting requirements are for your location? They're different. Some go straight to the local, some go straight to the state level for health. Okay? Have someone look this up. Call someone. I'm sure you get a lot of good response now. Okay? And again, hand hygiene, good old soap and water, paper towels, alcohol-based hand rub, be not only in the office, but people be showed how to use them appropriately so that we just don't go talk the talk but not walk the walk. And the disease will find a way through the weakest link. Okay? Hand hygiene, again, whenever there is any indication or exposure to bodily fluids, the number one thing is soap and water. And we're not just talking about a 10-second scrub. We're talking 15, 30 seconds. I mean, if we really think we've been exposed to bodily fluids to someone who is highly symptomatic, that's where we get the 3 to 5 minute scrub. And nothing is wrong with that. Okay? And don't forget to wipe down the surfaces the patient may have had contact with, also with the 1 to 10 dilution of bleach and water. Okay? Or disinfectant for viruses. Okay? And again, other infectious diseases such as Clostridium difficile or noroviruses. That'll be a greater chance of happening in your office than Ebola. Okay? But again, all you need is one Ebola patient to walk in. A family member of a friend of someone who came to visit somebody who came here for the holidays. Okay? Again, monitors. What they found that really helps, again, training, observation that it's being done correctly, something as simple as just making sure that your staff know how to wash their hands appropriately, and also then overseeing or supervision and intermittently checking that, making sure they're doing it, they continue to do it right, not just when they know someone's watching, but when someone, quote, may or may not be watching. That is where the challenges occur. Okay? Facilities, policies, and procedures, this is pure compliance. It is not written, it's not there. If you don't have any policies or procedures for communicable diseases, quarantinable communicable diseases, then there's a question, if a problem arises for any reason, whether you appropriately were prepared as a healthcare provider to provide healthcare for your patients, okay? And signs and symptoms, like I said, especially during respiratory season, this can be a financial impact upon practices, especially small office practices, but do you have face masks for when patients who come in with respiratory problems and respiratory infections, that they can put the mask on, and they can kind of semi-isolate themselves if they have to sit in your waiting room for any period of time and not cause others to get infected? Do you have the alcohol-based foam that's there for everyone, patients as well as staff to use? Okay? Not too many offices have the gowns. Not too many offices, unless you do procedures in them, have hair covers or other forms of protective, personal protective equipment. But do you want to consider having some? All you need is for one patient to walk in the door. But you're going to have tens of thousands, not individually, but collectively as physicians, we're going to have tens of thousands of patients with flu come in. Do we really want to expose everybody? And this is something that should be in our policies and procedures anyhow. We need to update them, but they should be there basically. Okay, policies include posting of signs of interests. Again, do you post it on the door? If you have any of the following, it can include things such as, have you traveled out of the country? Are you having significant bleeding? Please let the staff know immediately. Okay, where do you want it to be seen? As soon as someone comes in the door, before they even come in the door, and have your staff be aware of what to see, okay, what to look for, and what to ask. And again, have tissues, something as simple as tissues, so patients can cough into it. Masks, so they can self-isolate themselves in the waiting room if they have coughing and sneezing. And hand spray, alcohol hand foam, so that everybody can use it as soon as they need it and walk into your office. Okay, provide resources for performing all the above, and have space and encourage patients, if they have a respiratory problem, if you can get them communicable disease possible, how quickly can you get them into rooms away from others, especially if you have adults who have infections and those who don't have infections, or infections and immunocompromised patients sitting side by side. That can cause for major problems with your immunocompromised patients down the road, if not immediately almost. Okay? Okay, Ebola preparedness. The number one place you can get it is CDC, Centers for Disease Control.gov. That sends you to their main page, and then you can go put it in the search and just put Ebola, and you'll have more than you care to know. And the information about that is that it's constantly being updated. Each week, a minimum of each week, someone from your office should be assigned to see if there are any updates. Or sign up on the listservs where they send you out a new email every time new information comes out. And that's going to be a lot of information because it's just constantly updating. And you're going to find different sites are updated, some faster than others. So they may disagree with each other, so you have to look at the update dates. Because some may be a few months old, some may be a few hours old. Okay, now, what we as physicians need to be considerate of is medical decision-making and clinical judgment. Why do we feel a patient may have or potentially need to be transferred to a biocontainment center or or be placed on active or direct monitoring or isolation or quarantined? We need to put these signs and symptoms, not just patient presents with a cough and a fever. What is the exact fever? Put the exact numbers down. What is severity? Mild, moderate, severe. Rouse bronchi. What do you hear and what do you see during your physical exam? Do you have bruising where you ask the patient, how did you get this? And they go, I don't know. I didn't know that was there. These are the types of questions we ask and the types of information we document within our medical record. And also, we document what we do with these patients, what type of personal protective equipment is used when preparing and interacting with these patients. There's a question of types of PPE that were utilized at Presbyterian Hospital, because there's not complete documentation of, there's a question of the documentation of exactly when various components were begun. And so in order to rule out the problem, document. Document just means put down what needs that are there and why you feel this patient may have Ebola. Don't just say patient presents with cough, abdominal pain, and has a mild temperature. That's not telling anybody anything. Okay? How long have they had it? What do they perceive is getting better or getting worse? Why did they come to see you? Was this the reason they came, or did they have some other reason and you just happen to start asking the right questions? Document your medical decision making. Document your clinical judgment, both the inpatient and outpatient setting. Why? That's the number one thing. Document why you're doing what you're doing for your patient and what you did for your patient and why you did it. What symptoms and what severity of illness were you trying to monitor or to use as a diagnostic component? Okay? Things to consider. This is not necessarily completely for office, but number one thought that has come, a lot of questions have come regarding, if we think someone has Ebola, do we put them in outpatient observation? I don't think so. How many beds does an average hospital have? Anywhere between 200 and 400 beds? Okay, we can wipe that out with every single patient that walks in our office with flu. Any one doctor's office who walks in with flu this next winter can fill up that hospital if every single patient has to be in a private room, and everyone that comes in that room has to have PPE. You see? Observation, outpatient observation within a hospital setting is not appropriate unless we have a strong rationale for it. And then question, is outpatient observation even appropriate with a strong indication, or is full inpatient admission more appropriate to a biocontainment facility? And they just certified 2 in Virginia, one in Virginia Beach, Virginia, well, both of them in Virginia Beach, Virginia, one in Norfolk, one in Virginia Beach, that just got certified today, the first 2 in the country. And they have about 22 other hospitals that are in various processes of biocontainment. Okay? So how do you get them to that facility? Okay? EMS, ambulance, private car, with someone who's already been exposed to them, or if they haven't previously been exposed to them, then PPE entire way, all right? Regarding 2 midnight rule, for those, there's a question of if a patient is ill enough and you think a patient may have been exposed to or have Ebola, do you really think that patient is going to go home in 2 nights or less? Okay? That 2 midnight rule doesn't even need to be an equation. They should be either a home monitoring or a full biocontainment admission. And if you don't know and you don't have positive tests, then they are quarantined at home until something definitive come in, because the healthcare system cannot house all of the questions. But that is where quarantine came from, when the system could not capture and take care of all the potentials. We need to take care of the ones who are the declared diagnostic patients that are target audience. So now, CDC guidelines for monitoring exposed or potentially exposed patients. These controls and monitorings are the updated, because keeping in mind when Amber got on that plane, she had received okay permission because she had not had a fever prior to that time. So she reported to the health department that she was going to travel, and they said, okay, you've been asymptomatic. Of course, as soon as she gets on the plane, she becomes symptomatic. So that is one of the things we are keeping and being more and more aware of. Anytime in this 21-day period, all you need is to be asymptomatic, 4 hours later, they're going to start evolving symptoms somewhere if they have the disease. And we don't know when or where that's going to evolve. Okay? So active monitoring is this is a brand new definition, new to everything, including healthcare and the CDC. The state or local public health authority assumes responsibility, and what they do is they allow the patient to take vital signs twice a day, but they contact the patient directly. What is your temperature? How do you feel? What's going on? They don't wait for the patient to self-monitor and self-report. They actively contact the patient, even though the patient is doing their own monitoring vital signs or temperature at that time. Direct active monitoring is when they actually come to your home and do the vital signs for you. They check you and say, how are you doing today? Okay? Do your temperature. They do the temperature for you. They actively monitor you, physically monitor you themselves. And that is what has replaced just self-monitoring at home. Active and direct monitoring is to protect the people who are not infected. And this makes also the possibility that a person with Ebola who becomes or is exposed to Ebola, who efficiently declares themselves to have Ebola, is identified as soon as humanly possible. And then they are rapidly isolated and treated and evaluated. And then, again, blood work done to identify to see if they have signs and symptoms thereof that Dr. Holt will be going into. Okay? And so this is why we need to use the community health departments in working with the private sector in providing health care and maintaining the epidemiologic status of the community. Control movement essentially is people for individuals who have a reasonable, who've been exposed possibly to it. They aren't quite sure, they are asymptomatic, and so they're not allowed to use any long-term mass transit, such as planes, buses, trains, etc. There's a question of local use, and that if the patient has been asymptomatic, on-home monitoring or active direct monitoring, and they want to go a short distance, they can, with permission. They have to notify the health department or whoever's monitoring them, and then they can get permission or not. Just like Amber got permission to take the plane. But they have now taken public transit out of that, and they say you can travel any distance by transport or by personal vehicle. And then isolation and separation of an individual who is reasonably believed to be infected with the disease. Okay? That is until the disease has declared itself or they have definitively gotten lab results that the patient is positive or not. Okay? All of these have to do with patients that are not definitively positive for Ebola as of yet. They're either asymptomatic or minimal symptoms, but it's the cold and flu season, and they may or may not have varying degrees of exposure to someone who either had Ebola or someone who was exposed to someone who may have had Ebola. And so that's where the big question marks come. That is why we monitor people from home. Okay? And then quarantine is basically the separation of individuals from the entity, from the population, until it is determined if they have a quantifiable communicable disease or not. And the biggest time and the most patients will be the or not. But we don't know which ones will be the have it and which ones that will be the don't have it. So we have to look out for the public health in the process. Because can you imagine trying to contact every person who may or may not have had contact with someone over X number of days if they're going out among the community, throughout the community? It's easier for them to have contact with family members and for these people to be monitored also if the patient who is the target patient develops true Ebola or any communicable disease. Any questions? This is where we will stop, and Dr. Holt will take over and go into other components. Okay? All right, thank you. So one question, and then we'll